So, ladies and gentlemen, it's an honor to introduce you Michael Wang, professor of neurosurgery of University of Miami. He's really an honored specialist in minimal invasive surgery in dealing with costs and evidence-based, published many papers out of that issue. And I'm really happy that we have him here. He's a very intensive, good speaker. I like his lectures. And Michael, now it's your turn. Thank you for coming such a far distance.
Great. Thank you, Professor Arand. It's really a pleasure to be here in Germany and really an honor to talk about a topic that I have tremendous passion for. And I'm going to entitle this Ultra MIS Spine Surgery because it's the next wave of what I think is coming. So these are my disclosures. And let me just start by saying that, I've never been to Stuttgart before, but I started to read about it, and I do love cars. And this is a place that's very special. We are in the land of efficiency and precision and excellence, not just Germany, but Stuttgart in particular. And that's really going to be the theme of what I'm going to tell you about in the setting of spine. Now, I've had some close German friends over the years. Bernhard Meyer, I've known him since I was a resident. Michael Puzo introduced me when he was in training with Johannes Schramm, and we became fast friends. And of course, Professor Arand and I are now colleagues as well and friends. And so very excited to be here to talk to such a serious audience. So, I'm going to obviously have to give this lecture in English, so I apologize if I speak a little fast. But the overall concept is that, why are we here? We're here because things are changing. And everybody's interested in the concept of evolution. But the flip side of evolution is obsolescence. People worry about this. What does that mean for me as a surgeon and my surgical techniques? So let me show you an important slide. This is something I learned in business school. This is a concept called Baumol's cost disease. If you look across the spectrum of industries, right, everything that we see gets more efficient, less expensive, and better. Look at automotive technology, right? The simplest car of today is superior to the most amazing car of 30 years ago. There's two exceptions to this. One is in healthcare, and the other is in college education, right? Now, I'm not saying we don't do things better or more efficiently or less expensively, but it is not keeping pace with what's demanded by the business world. So let me give you an example, and this is not to take Moore's law in computer science and translate it directly to healthcare, but this is the computing power cost of an iPad. iPad 2 costs 120 euros or something like that. If you go back just a decade, forget about going back 30 years, the cost of that kind of power goes into the trillions of dollars for what you have on your cell phone today. This is what we are looking at as in terms of efficiency and what's being demanded in terms of medicine. So why do I even talk to you about this? Is it even possible? Because this is what keeps me up at night. This is what keeps me awake, are the existential threats to spine surgery, right? These are real threats. It's very possible for spine surgery, as we see it today, to very quickly have problems because of all of these issues. So I've spent my entire career focusing on these various elements. For example, how to deal with aging populations, how to deal with people who are sicker, right? How to deal with obesity, how to deal with costs of care, and how to manage increased fear of spinal surgery. So these are real issues that impact every one of your practices when you go back home. So I've spent my career trying to get smaller, like the little furry mammal. So unlike the giant megafauna, the giant reptiles like Tyrannosaurus rex and the dinosaurs of the past, I want to be the little small furry animal that's going to survive the next big apocalypse. And I'm going to come back to this. So let's talk about what most people know about. So if you say you do an MIS TLIF, you can say you're an MIS surgeon, right? So it's the workhorse. You can do all these things like decompression, you can do fusion, you can do correction of spondylolisthesis, and you can do it better because it's MIS, right? And this is becoming very well proven now. Here's a meta-analysis from Kevin Foley looking at reduced pain. This is a forest plot. On the left side of this line means that there's less pain. I think we all understood this is quite mundane. Earlier normalization of life. This is how people get back to work and play. This is from the Vanderbilt group showing, of course, people are getting back to their normal lives faster when they do MIS surgery. No argument there. This is one of my papers on infections. Rates of infection to MIS much, much lower because we don't disrupt the soft tissue envelope. This is a study on CSF leakage by Rick Fessler, again, another forest plot, looking at the fact that you see a lot less CSF leakage, just a very simple basic complication, right? And of course, reductions in narcotic usage. So if you're using less narcotics, the patients are going to generally do better. It means they have less pain, and these will show basically how that all looks. So we know all of that, right? But what is MIS? I can tell you that it's very likely that no two surgeons in this room do the MIS TLIF the same way. Everybody does it differently, right? Is MIS a technique? Is it a technology? Is it an approach? Is it a marketing ploy? Is it a philosophy of surgery? Or is it a philosophy of care? In other words, how you manage these patients. And so this slide just kind of shows you all of those 6 different dimensions of what one might consider MIS or what one might not consider to be MIS surgery. And this is a very important point. But let's take a look at what that technology looks like, because the exhibit hall is next door. This is a slide, cover of the JNS spine put together by one of my fellows showing the covers that were MIS surgeries over the history of 20 years, right? So you can see the evolution. I see Professor Buttner-Jans here, who is a great innovator. There are many innovators in this room, many German innovators in MIS and other arenas, right? And what does that really mean? Is it technology, right? So for example, here's the simplest level of analysis. Is a tubular surgery MIS surgery, right? Many people suggest that tubology, use of tubular retractors, defines MIS surgery. Well, I'm going to challenge that a little bit, because if you look at a MIS TLIF, what size tube is being used? Does anybody know what the average size tube is used for an MIS TLIF today? Well, I can tell you what it is in the United States of America. The average size portal tube is 28 millimeters, okay? That's the average. Now, if you hear that, you can say, well, I understand why the open surgeons don't really believe in MIS. Some people would say a bigger than 1-inch tube, is that even much less than what is normally done with an open surgery? One could call into question whether that's the case or not, right? So we started in the early TLIF days doing 14 millimeters. We've doubled that size and diameter. And what does that really mean? That's just a number, right? If you took 2 tubes, 24 and 16 millimeters, the difference in the area of tissue displaced and the volume of tissue displaced at an 8-centimeter depth is 3x, right? So when people say, I used a tube, I used a retractor, whatever, does that define MIS surgery? Is that what would mean that the patient had an experience that was MIS? So my life changed when I started to travel the world, and I know that endoscopy has much of its origin here. I believe it's in southern Germany, right near the Swiss border. I'm an American. I don't know the geography of the globe, only America. So I don't know, but I think it's in Germany. It might be in Switzerland where they make all the endoscopes, right? But we know where most of them are being sold today. They're being sold in China and Asia. So this is a slide that was given to me by Wolfgang Reis from Joymax, showing 1,000 spine surgeons that are users of just Joymax. Forget about all the other manufacturers of endoscopy. I'm not trying to say Joymax is better or worse. This is just a simple analysis. And I said, wow, how can all those people be wrong? Are those people all wrong? Are we all crazy in America that we don't believe in endoscopy? And here I walk through exhibit hall and I see, wow, there's so many companies selling endoscopic equipment, right? And so, so I started down this journey and said, okay, look, you can do bigger surgery through the endoscope than you think because you can see more, you can see differently. And it was a new skill set. I used to say I wanted to learn one more kind of surgery before I got too old to learn anything new. But I took a different direction because all of the other endoscopists went one way and I went in a different path. And I said, listen, we're going to use the endoscope to do the big surgeries. So we started to analyze what this transforaminal space looked like and started to refine our concept of what Cambin's triangle really was. And Lou Toomey-Allen from the Barrow Neurological Institute and I started to study this, and it's really Cambin's prism. It's a three-dimensional space that you have to understand better if you're going to navigate it well, right? And we started to explore this idea of maybe we want to do the big surgeries endoscopically. In other words, we want to do fusion, and you're going to see later, we want to get to deformity, okay? So this is an example. We started to classify the endoscopic access. I know this is embarrassing for the endoscopists in the room. You're like, this is so simple. It's not that I'm a great endoscopist. I'm not. I just wanted to take this in a different direction. So we started on a road back in 2013 with the concept of an awake lumbar fusion. In other words, doing surgery without using general anesthesia. And at the same time, we launched a first in the US successful ERAS program for spine. Back at that time in 2012 at NAS, I remember a room bigger than this, and we asked, does anybody know what ERAS is? And not one person could raise their hand. We know that ERAS was invented in Denmark, and I know the Germans, you guys are very, very familiar with ERAS. Americans are just catching on to this now. But the idea was to do ERAS, this is colorectal ERAS, and take this to where it's needed the most, which is in the arena of spine surgery, okay? So what we did was we took the technical features, it's not really ERAS, it was just our awake fusion method, and we used the endoscope, we used awake anesthesia, we used percutaneous fixation, we used Exparel for analgesia, expandable interbodies, and we use off-label infuse, right? So these 6 dimensions, these 6 products put in together, allowing us to do surgery, percutaneous, endoscopically, awake, ERAS, spine fusion. So this is what it looks like, MIST lift done in about an hour or less. And this is the first case I ever did. Some of you have seen this movie because I show it all the time. I like to show it because here I am talking to the gentleman. This is the former dean of FAU Business School, so this is not a rat lab. We're taking care of serious people. And we're going to do a surgery that looks like a normal surgery. Now in America, there's a concept of owning a surgery center. If you're successful, you want to own your own little surgery center and get all the passive income. You're owning essentially a part of a hospital. And so the American surgery center docs have their own recipes of how to do a fusion or a non-fusion and get the person out of the facility, right? This is not about that. This is about trying to change the experience for the patient. So the endoscopic parts are very, very straightforward. But we're going to then do a formal fusion. We're going to take the whole disc. We're going to clean it. We're going to do bilateral pedicle screws. We're going to do cages, all that stuff without using general anesthesia to change how we do surgery. So you can see automated brushes to clean the disc space, to get all this set up for a fusion. And again, do this with almost 50, 40 cc's of blood loss in the entire procedure, right? So this is an example patient 1 hour after surgery, no narcotics, okay, walking around the recovery room, she can easily go home. This is not about running a surgery center. There's a lot of levels at which people look at this and they go, I don't really understand what you're trying to do. What is the purpose of all this, right? So we've published on this. I don't want to belabor too much the data. I know the Germans love data. You can look all this up on PubMed. I'm not going to go into it. We have a sedation protocol. This is a very complicated protocol by which we monitor patients so we can do this successfully. And these are the reasons why we do this, right, without general anesthesia. And I'll go through this in succession. So first of all, it's the most sensitive neuromonitoring. So the only structure at risk when you do this surgery is the dorsal root ganglion. So we wanted to make sure that we were not going to hurt the dorsal root ganglion, and we've now published the EMG thresholds of the DRG on this approach. This is a patient giving me thumbs up, ready to go with surgery, ready to have this operation. Very important to understand this anatomy, right? It's not about trying to make the hardware look perfect. It's about not hurting the DRG, which is unlike almost any other surgery we do as spine surgeons, right? It reduces the effects on patient cognition. My average age of patient is 73. I regularly operate on 90-plus-year-olds, okay? Because in Miami, we call it God's waiting room. People come there to retire and die, right? So basically, we have to take care of them, right? So this is a paper showing that they're recommending that you don't ever use general anesthesia even for children, right? But the idea here is there's a brain risk with surgery. A lot of folks will tell you their brain isn't the same after surgery. Fewer derangements, right? Cardiac, right? All this cardiac stresses, right? The paralysis of the vocal cords, right main stem intubation, aspiration, all these things, temperature regulation, homeostatic methods of dealing with this. We don't use a Foley catheter, right? So we don't have urinary retention as often, right? This is an example I like to show. This a person had arterial line. They put the arterial line in. It dissected across the arm. The patient had to wait 6 more months for her surgery for this to heal. She always shows me her arm. So this is an example. This is a 86-year-old with a cardiac ejection fraction of 11%. That means typically no surgery. But we're going to do this surgery. You can see pacer pads are on, and we're going to fix this grade 2 spondy with this patient without using general anesthesia. So this is what we're trying to accomplish, taking care of the sicker people through all of this. And the studies show elderly patients can benefit just as much from spine surgery. Okay, what about the size of the patient? The size of the patient from a technical factor doesn't matter. Okay, now it may matter for the awake part, but this is something that you'll see, like for example, here's a patient in lateral position, BMI of 53. This is an executive from a major spinal device company, a high-level executive, and you can see when you do the surgery, you can get good improvement if you do the right surgery on the right patients with the right indications, right? Targeting and access, I said this already, very important. If you haven't done this kind of work before, very important to understand Camben's triangle, and I'm going to say it again, the dorsal root ganglion and its relationship to the facet joint and your access to the disc, right? Discectomy, very important to do a proper discectomy to get the end plate prepared. You can see here the bony end plate being prepared to prevent non-union. This is very important from a technical perspective, right? And so you can see here, we've prepared this end plate ready. The cartilaginous end plate has been stripped, so we're going to have a low non-union rate. Indirect decompression. You have to believe that this works to be able to do this. So we do a lot of spondylolisthesis here. You can see a patient who has a one-level surgery, obviously many levels of disease, and this is after the fusion, getting that resolution with that indirect decompression. So we've done this over 400 times now. We have an immense experience with how this procedure is done, what the pitfalls are, what the benefits are of this, right? So take a look at the complications. So transient DRG symptoms, right? That's the most common thing. Irritation of the DRG, permanent much less. We're very, very careful now about this because that is really the structure at risk. The thing we were really worried about was delayed non-union. We have not seen much of this. This is probably due to our use of BMP off-label inside the disc space. So all of these features make it so that, for example, here we've drilled out the SAP to allow us to access the disc space at this level that's really almost like a transitional segment where it's difficult to access because of the pelvis and the facet joint. So we've actually taken the time to drill that out endoscopically to gain access and avoid injury to the DRG. So why do this, right? Because this is something a little bit awkward, a little bit odd when you first start it. So let me show you a slide I used to show. This is about the cost of surgery, and I used to say the area under the curve is the cost of doing the operation. That could be measured psychologically, philosophically, it could be social, it could be economic, it could be societal, right? So there's a cost of surgery. And I said, well, this is what we are trying to reduce in MIS surgery to get people back to normal, and I've been talking about this for 20 years. Then about 10 years ago, I started to say, well, let's bend this curve down. We're going to take this curve down, take it down so it looks reasonable. And I said, this is our goal with the Awake Fusion. Now, I'm going to show you what we've actually done with this, okay? So we have been doing this sort of objective activity tracking. Some of my former fellows and I, we started a project, became a company. It's not with wearables, it's using your cell phone. And so this is a paper from Stanford from one of our former fellows showing how you can use the Apple Watch, right, or Fitbit kind of thing, right? So we didn't use this, we used people's iPhones, right, because the iPhone can do this too. And there's advantage and disadvantage. We could spend an hour talking about the technology and why we do this, but we're basically monitoring people's activity live, real time, minute by minute, hour by hour. So I'm going to show you the slide. This is an example of a patient who starts with this kind of level of activity, hires better, and then decreases because they have problems, and then has surgery here, and then decreases more because we say put the brace on, don't do anything, and then activity is restored. This is the benefit of surgery, and this patient actually ended up having pancreatic cancer, so you can see the effect on the back end, right? So that shows you the granular detail of what's happening with activity. Now let me show you a different slide. This is two different patients. The red is the Awake Fusion. The blue is a microdiscectomy. We call this recovery phenotyping. It's like a fingerprint, right? So you can see that we've taken a surgery that is essentially a fusion and turned it into the background effect to the patient of something like a discectomy. Now, this is a very dangerous slide because it's like giving you a very powerful weapon. Should we just fuse everybody? That's not what I'm suggesting. What I'm saying is that given this kind of tool, maybe you can treat patients that you didn't treat before. And if you look at narcotic usage, this is MIS TLIF versus Awake TLIF in orange. This is my cases. And in the US, we have a big narcotic problem. I don't know if you have this in Germany, but 109,000 Americans died last year from narcotic overdoses. So this is a real thing, and it's a real issue for us as a society, right? What about cost, right? Marcus asked me to talk about cost. So this is, again, me versus me. This is the Awake Fusion. Average cost, very, very hard to get cost. This is true cost data. This is not imputed cost. This is real cost. $19,000 versus MIS TLIF at $22,000. So we're saving 16% on cost. Hospital loves it. We're making money hand over fist for the hospital, right? They're very, very delighted at that kind of a thing. But you may say, well, I don't care about the hospital. I care about me, right? I care about my life. Well, okay. Here's an example I took of myself against myself, 2 different days. Both days we're doing MIS TLIF, this one under general anesthesia, this is Awake. So here we go, okay? So this is from the electronic record. 7:25 is the time in room. So both days we happen to get in room at the same time. Pretty good, 5 minutes ahead of time, right? But then the prep start is when you can prep the patient. So in the regular surgery, 7:49, that's pretty good, right? That's like 24 minutes, you're ready to flip the patient, right? And this is here, 7:32, why? Because you don't have to put the patient to sleep, okay? Patient flips himself over. Then we got a prep start, right? So we got to have incision. Incision here is now 11 minutes later, right? Why? You got to hook up the bovie, light handles, right? All that stuff. We don't do that with the Awake Fusion. We don't use light handles. We don't use bovie. So 7:38, okay? So now I'm 22 minutes ahead of myself. Now we're going to do the surgery. Here we finish at 10:56. Here 8:30. So now I am 126 minutes ahead of myself. Oh, and then you got to wake the patient up, right? So on this side, you got to wake up 10 minutes. That's pretty good, right? Anesthesia is doing very well today. Here, 5 minutes, okay? So I'm 151 minutes ahead of myself on the first surgery. Now you can see how I can finish my first fusion surgery before anybody else at the University of Miami has even started their operations in general surgery, urology, orthopedics, ENT, neurosurgery, whatever, right? Now think about that, 151 minutes. Now let's just assume, I'm not saying you're going to do this 100 times a year, but let's just take 100 cases, okay? You do that 100 cases, you do that in a year, you say 15,100 minutes, that's 251 hours, that's 10.5 full 24-hour days. Think of what you could do with 10.5 full 24-hour days. Now you know how I got my MBA in 1 year. This is about efficiency. This is about saving you time and getting the job done, right? Getting smaller, small footprint, better effects, right? Now, let me take you back to a time you may have already forgotten about. I remember the COVID pandemic like it was yesterday. I remember making the claim at the spine section, 1 million Americans are going to die. I said that in February of 2020 because I saw Taiwan shut down. Many of you have probably already forgotten about this, about what it was like during the pandemic, all these horrible things that happened. People were getting fired, people were getting salary cuts. All these horrible things were happening. And then, this is from the US president, okay? Proposed phased approach. This is April of 2020. So at the present time, whether you like it or not, doesn't matter. This was the declaration. Phase 1, you can reopen, okay? Elective surgery can resume as clinically appropriate on an outpatient basis. Now, I will live another 100 years and never hear the German chancellor or the American president talk about elective surgery to the whole world. They're not going to talk about it, but they're talking about it to 300 million people on this day in April, right? So what does that mean? That means that I'm operating and you're not. And now you know how we did 600 cases during pandemic. I'll show you how. So people were afraid of coming to the hospital, right? People worried about all these things, right? What's going to happen to the future? And the pandemic was just the first test, but I'll show you what it looked like, okay? The differences are going to matter. Are you really MIS? Are patients going to need to stay in the hospital? Do you need an ICU bed, right? Do you need rehab, right? So this is a lady, an English lady that saw me in February of 2020 who said, I can kind of get along and, I'm still managing with injections and, whatever. Then in April of 2020, I was looking at the electronic record because everybody was a little bit more at home, and I saw this message come across said, I'm going to kill myself. I'm like, that's a little odd. I got a lot of patients. I don't see a lot of messages like that. I called her, and she's crying on the phone. She goes, Dr. Wang, I'm going to kill myself. I can't walk to the bathroom. Nobody's here to help me. I have kids. My husband's working. What do I do? I'm like, what's going on? She goes, my leg is on fire. I can't do this anymore. So I call the hospital and say, I want to do an MIST lift. They're like, are you watching the news? There's no elective surgery. There's none of that. We're only doing emergencies. There's no nurses. It's all COVID. I said, listen, let me do this surgery, okay? And the CEO says to me, do you need anesthesia like intubation? Because remember that time. Remember when the anesthesia would intubate, then everybody stay out of the room, 15 minutes, right? And then you wait. Okay, now we can maybe go in double mask, right? It's crazy, right? You remember that time? I said, you don't need intubate, because we thought that those neurosurgeons died in Wuhan because they were doing endoscopic transsphenoidal, right? So I said, put the nasal cannula on, flip her over, we're going to do this, right? They said, do you need to stay in a hospital because we have no nurses? I'm like, no. They're like, well, okay, try it. So we do the surgery. Okay, here it is, right? Simple. It was a 40-minute surgery. Okay, corrected her. I get a call 3 days later. Okay, she went home, right? All better. The CFO, the chief financial officer, calls me and says, Dr. Wang, what did you do 3 days ago? I'm like, oh, God, I'm in trouble again. He goes, no, what did you do? I'm like, I did an elective spine surgery. He goes, keep doing that. And as all the hospitals around us shut down and open, shut down, open, shut down, open, we sucked in all the patients in Miami. It's how we did 650 surgeries in a year of 2020, elective, right? So you have to understand that's a crisis, right? That's an existential threat. What's next? Sigma strain? payer resistance, international medical tourism, protracted economic recession, aging patient population, economic pressure, because you remember what happened right after they opened. They said, get back to work. We need to make money now, right? And what is going to dictate this? What is going to be the next thing that happens, right? So the next stages are, of course, things that are quite interesting. Now, some people say, I don't like Awake. Why don't we do something different? Why don't we do the robot? Oh, that's a good idea. Now you can use the robot and all the other pieces to do this, right? Because robotic surgery is definitely the future. We're talking about something that's not technically more difficult. We're talking about standardizing surgery, right? And I tell people the robot is amazing because you can build a robot to any constraints you want. Okay? We've published on this. We've published on doing a robot for endoscopic drilling, for all of these things that we like to do, awake T-lift, but asleep, right? Percutaneous endoscopic T-lift. All of these things we love the robot for. Augmented reality, right? This is T-lift with augmented reality. All these tools that we love, right? A lot of this technology invented in Germany, right? That we can use to make surgery safer and better for our patients, right? So what about deformity surgery, right? So, I've talked a lot about deformity MIS surgery. I love it. I think it's amazing. It's the future. There's so many different kinds. It's the big growth area. The companies all want it. Some surgeons think it's the way of the future. I don't know if it is or not, but deformity surgery is a big deal, right? You use the Google Complete, it auto-completes. These 10 are the first hits. None of those look good, right? Surgery of deformity of the spine is very complicated. We have to combine technologies. This is the principal paper showing using multiple antivirals was the key to not defeating, but essentially suppressing HIV when it was viewed as a death sentence when I was in medical school. So the advantages of deformity surgery, reducing costs, preventing PJK, clinical improvements, coronal correction, and now sagittal correction, all been proven. I'm part of the ISSG. It's an amazing adventure to talk about deformity surgery. I'll just show you one very quick thing. This is the MIS mini open PSO that we invented in Miami, basically using 2 rods, sorry, I'm going to run out of time, percutaneous, pedicle screws, iliac screws, all of this stuff to get stuff done, right? Breaking the spine with the PSO site, using the Viper Prime system, and this is the kind of stuff we think is very cool. But it's still a big surgery. You're still doing an osteotomy, still breaking the spine, you still lose some blood with this, and it's significant, but it changes a lot of what we're doing in terms of the surgical intervention, right? This is an example. This is a mother of one of our medical students. Sagittal correction. This stuff is 11 years old now. These slides are all very, very old for me. Stuff like this is a very, very complex deformity. This is probably not good enough correction. I look at it now, I'm like, that should have been corrected better, but that's with the MIS mini open PSO. And then now the concept being different, being not just about the technique, but maybe going shorter segment. This is an anterior column resection. You've probably had lots of lectures here at this meeting about this. Going short segment to get the deformity correction that you need, right? Instead of a T10 to pelvis on everybody. And this is where we're headed with the Awake Fusion. This is a 3-level Awake MIS T-lift done. This is a small curve, right? This is very degenerative, but this is a surgery done in about 2 hours with 85 cc's of blood loss, right? This is the stepping stone of where we're headed with all of this, okay? So are we going to get sagittal correction with the endoscopic fusion technique? The answer is yes. We're already getting it. But are we going to get it as effectively as we need to? I would venture to guess that as long as the spine is not completely rigid, that we're going to be able to accomplish that. And we're going to do it on the backs of the lateral surgeons. We're going to do it by sectioning the ALL, right? So I want to introduce a concept to you that's a little different. How many of you have children? Everybody, right? Almost all of you. Okay, my 3 kids all had orthodontia, braces, right? Okay, I'll tell you what the orthodontist did not do. The orthodontist did not say, Mike, what I'm going to do is I'm going to take your daughter, I'm going to take a hammer, I'm going to knock all 32 teeth out of her, and then I'm going to implant 32 perfect teeth. Because I'd say, no way would I let you touch my daughter. But that's kind of what we're saying to our patients, right? We need to do this drastic thing. They put the braces on, they make an adjustment, they let the body adjust, they adjust it again the next month, they let the body adjust over time slowly. So what if we could take a spine surgery and think about it like an orthodontist? I love the dentist because there's something like about 32 teeth, give or take. There's something like about 32 segments of the spine, give or take. They're hated, we're hated. There's a lot of parallels to dentistry and orthodontia. So what if you could take a complex surgery, a very complex deformity surgery, and break it into parts? Instead of 9 hours of surgery, you break it into 4 surgeries over 4 months. You let the body recover, you let the patient recover at each time. That is definitely, sorry, just did that for fun. that is what we're trying to do. So we've begun the process of sectioning the ALL endoscopically, to cut the anterior longitudinal ligament endoscopically, to release the spine, to get sagittal and coronal correction. And this is just a paper we published on that, right? Doing that, showing that could be done. What if you could do this without using general anesthesia each time, right? What if you could do this with modular implantation? In other words, when we put in pedicle screws, like that's the construct. What if we could put in 4 screws and then come back without undoing that and put in 4 more screws? And then do that and build this construct internally within the patient. Now you can see how you could take someone who's very sick or very old or very challenged and maybe get a very, very complex surgery done. So that's my vision of the future. I know that many of the people I see in the room are really master surgeons, and I really am curious to get your input and insight on a project that we can work together on to help our patients collectively. So thank you very much. Thank you, Marcus, and thank you, Bernhard, for having me here. Over a little bit. Good? Okay. Any questions?
Thank you very much.
Yeah.
Thank you.
Sorry, I ran over, so. Yeah.
So, es kommt die nächste Session. Bitte die Vorsitzenden. Wir machen sofort weiter.